So, talking about hyperkalemia, hyperkalemia is defined as plasma potassium level more than 5.5 milliequivalent per liter. This is again a very important thing which you should know and asked many times in the exam are drugs which causes hyperkalemia. First and most important are ACE inhibitors like captopril and enalapril along with ARBs, that is angiotensin receptor blockers, losartan. Potassium sparing diuretics like spironolactone and amiloride. Digoxin, again very important because many patients of heart failure are on digoxin usually. Non-selective beta blockers, NSAIDs, KCl tablets itself, and heparin. Now coming to the next important entity which is usually asked, that is ECG changes in hyperkalemia. It depends on the level of potassium levels. Now when potassium levels are 6 to 7, it causes tall peaked waves. When 7 to 8, it causes loss of P waves and widening of the QRS complex. 8 to 10 milliequivalents, QRS merging with the T waves forming sine wave pattern. More than 9, it will cause AV dissociation, ventricular tachycardia fibrillation, and cardiac standstill, that is asystole, right? So these are the peaked waves, prolonged PR interval. So what is the definition of peak T waves? So this T wave should be more than 50% of the preceding QRS complex. Loss of P wave, prolonged QRS complex, ST segment elevation, and ectopic beats and escape rhythms. Then this is sine wave pattern, VF, asystole, axis deviation, bundle branch block, and fascicular blocks may be seen in case of hyperkalemia. So most importantly, you see is tall peak waves, but you should know at what level of potassium what changes are seen on ECG and how they exactly look on ECG. This has been asked many times. Now coming to the emergency treatment of hyperkalemia. So potentially fatal hyperkalemia is serum potassium more than 7.5, profound weakness, absence of P waves, widening of QRS complex or ventricular arrhythmia on ECG. So first is you have to antagonize the membrane effects of hyperkalemia. For that you will give calcium gluconate, that is 10 ml of 10% calcium gluconate IV slow over 10 minutes. Right. After that, you will cause the immediate effects. To counteract the immediate effects, potassium will move inside into the cells. To move the potassium inside the cells, we'll give insulin along with glucose, insulin dextrose strip, injection of sodium bicarbonate, and beta 2 agonist like salbutamol inhalation. Removal of potassium from the body, that is a definitive treatment, is loop or thiazide diuretics, cation exchange resin like kexalate, and peritoneal dialysis or hemodialysis. So it is very important to remember that if sodium potassium is more than 7.5 or if there is profound weakness or absence of P waves or widening of QRS complex, ventricular arrhythmias or ECG, it is considered as potentially fatal hyperkalemia and it requires prompt and emergent treatment. Otherwise, it is very difficult to save the patient. So first coming to calcium gluconate. So intravenous calcium serves to protect the heart. How calcium gluconate acts in case of hyperkalemia is it raises the action potential threshold and reduces excitability. So it will increase the action potential threshold which will reduce the excitability. Now if you go back to your physiology basics of action potential of depolarization and repolarization, when depolarization occurs or action potential occurs only if the stimulus is enough to raise the depolarization beyond the threshold. So what calcium will do is it will raise the action potential threshold. So more stimulus is required for generation of action potential. Thereby, it reduces the excitability of the heart. As mentioned earlier, calcium gluconate is given as an injection in 10% solution in a 10 ml ampule over IV slow. Remember, you have to give it very slow, otherwise it will cause again bradycardia and cardiac arrest. So calcium gluconate precaution should be taken as it should be given very slow over a duration of 10 minutes. So other treatment modalities are, as mentioned before, is insulin glucose drip. Now, why if you give only insulin, insulin will cause movement of the potassium inside the cells. And why we give glucose along with it? Because to reduce potentiating hypoglycemia, which is caused by insulin. So dextrose or glucose will counteract the hypoglycemia caused by insulin. That's why you give a insulin dextrose drip. Sodium bicarbonate infusion, beta agonist like salbutamol also causes inward movement of potassium into the cells. It is given in the form of inhalation, actually in the form of nebulization. Loop and thiazide like diuretics or thiazide and thiazide like diuretics, it will cause excretion of potassium through the it will cause excretion of potassium through the urine, but it does not have immediate action. It takes time to act. So the most in an acute hyperkalemia or in an acute ECG changes, the treatment modalities are these three, that is insulin glucose, sodium bicarbonate infusion and beta adrenergic agonist. Loop diuretics, cation exchange resins and dialysis are used for long-term management of hyperkalemia. Cation exchange resins, they are given orally. They come in the form of sachets. You take it with water, usually twice or thrice a day, depending upon the requirement. So it will prevent the absorption of potassium and from the intestines, and it is excreted. For dialysis is the definitive treatment for hyperkalemia. You can do dialysis in two forms. One is hemodialysis and the second one is peritoneal dialysis. So resistant hyperkalemia is one of the indications for emergency dialysis. So this is also very important. Specific treatment in case of hyperkalemia, in case of specific disorders. If the patient has Addison's disease, you have to usually treat it with glucocorticoid or hydrocortisone therapy. So in case of Addison diseases, because of glucocorticoid and mineralocorticoid deficiency, so there is hyponatremia and hyperkalemia. So this hyperkalemia cannot be treated by the usual measures mentioned before. You have to treat the cause of it, treat the disease. So the treatment of it is glucocorticoid or hydrocortisone therapy. Hypoaldosteronism. So aldosterone usually causes sodium and water retention and excretion of potassium. So hypoaldosteronism, when the aldosterone is low, it will cause reversal of effect. It will cause hyponatremia and hyperkalemia. So you will have to majorly give mineralocorticoid supplement like fludrocortisone, which the dose is 0.2 mg per day. Now, hyperkalemic periodic paralysis, you give prophylactic beta 2 agonist inhalation. Treatment of diabetic ketoacidosis. Now, treatment in case of diabetic ketoacidosis, patient usually present with hyperkalemia due to insulin deficiency. So the treatment of hyperkalemia is the treatment of hyperkalemia in case of diabetic ketoacidosis is insulin therapy. If the patient has dehydrated, it might present as hyperkalemia. You have to correct the volume depletion. Correct metabolic acidosis. So as mentioned in the previous slides, acidosis will cause hyperkalemia. So you have to correct metabolic acidosis for treatment of hyperkalemia. So metabolic acidosis is generally associated with hyperkalemia. So the acidosis, you have to give an alkali, that is sodium bicarbonate. comes as 600 mg tablets 2 to 3 times a day, or sodium citrate, which is SOH, which is salt solution, SHOHL apostrophe S, which is given in the dose of 10 to 15 ml 3 times a day.